healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. Welcome back to Coffee with Coker. My name is Mark Reibold, and I'm the host of the podcast. And on today's episode, we have another episode in our series that we call Vendor Spotlight. And if you haven't heard any of our other vendor spotlights, just real quickly, basically all this is we have a few minutes to sit down with representatives from different companies out there in the healthcare industry. A lot of these happen to be technology companies that we come across, whether it's a technology solution focused on security and compliance or communications and other services as well, though. And on this vendor spotlight, it's Jeffery Daigrepont coming back again with another interview with a few of the executives from a company called ChartSpan. And what ChartSpan does is basically it's management services, but they're centered on improving quality and achieving quality-based metrics while also hitting financial targets. And this is one of those things that is obviously becoming more and more not just prominent, but essential for healthcare services organizations, whether you're a medical practice or a large health system. As we move into more of a quality-based dynamic, and kind of achieving those reimbursement targets that are tied to quality metrics is critical, needless to say. And so the folks at ChartSpan sat down with Jeffery for a few minutes to talk about some of the things that they bring to the table and their services and solutions, and some of their kind of experience that they've seen thus far out in the marketplace. Jeffery sat down with a gentleman named Jon-Michial Carter, as well as Angela Stokes, who are, again, two executives from ChartSpan. And like we've said in some of the past vendor spotlights, these are just companies that we come across out there in the industry. We don't have any formal affiliation with them or any of these others, formal or otherwise, frankly. Again, these are just kind of intriguing and interesting companies and solutions that we come across that we think could be informative for our audience to hear. So we just want to bring that out through our forum, and you can kind of take from it what you will. But we hope you enjoy it. As always, you can hear this episode as well as all of our Coffee with Coker episodes via our website, and that you can find those at coffeewithcoker.com. You can also find us directly via the Coker website, which is cokergroup.com. You can find us on social media as well, LinkedIn, Twitter. And we encourage you guys to not just follow us and subscribe wherever you like to listen to your podcast, but also we love your feedback. So if you have recommendations for a topic you'd like us to cover, or maybe a company you'd like us to incorporate into a vendor spotlight in the future, we'd love to get that feedback. If you have questions about anything, whether it's this episode or any other episode, again, you can reach out to us directly there at the website. Once more, that's coffeewithcoker.com. Again, we hope you enjoy this discussion, and we look forward to bringing you more content like this in future episodes. But thank you for listening.
All right. Thanks, Mark, for that introduction. As Mark indicated, we are featuring another one of our vendor partners today, as we always often like to do, is feature innovators in our industry. So today, here with us in our studio, we have ChartSpan, and we have the founder and CEO, Jon-Michial, and Angela Stokes, VP of Quality. So welcome, guys.
Happy to be here.
Yeah, thanks for making the drive up. Probably goes without saying, we're seeing a lot of interest in the area of chronic care management. So before we get into the specific questions that we have, maybe, John, do you want to just give us a little bit of an overview of your company, what you guys do, and what gets you guys up in the morning?
Sure. So we are a managed service provider of value-based care solutions, which is kind of vague. There are three specific things that we do well. Most notably is chronic care management. We're the largest managed service provider based on enrolled patient population of care coordination solutions in the country. Specifically, Medicare has a program called CCM, or chronic care management, and we administer that program as a managed service for more than 100 health systems, clinics, and practices around the country. We also do annual wellness visits which has been a challenge for many organizations as they try to get to any real volume. And we have a unique way that we do AWVs under the value-based care heading. And then the third leg of what we do is quality. We provide MIPS and quality services, again, as a managed service for our customers.
Outstanding. That's quite impressive. When did ChartSpan get started?
About 4.5, 5 years ago.
Okay.
We actually spent the first couple of years building out the product, building out the service. This is operationally the most complex business I've ever been a part of. And I've certainly been a part of many in my career. What we've learned is you can't show up with a minimally viable product in healthcare. If patients or rather providers and health systems are going to trust you with their patients, you have to have a very polished, disciplined, managed service in order to succeed in this space. And we spent a lot of time thinking through that process, the technology, the people. And today we're proud of that service that we deliver.
I was going to expect that you were going to stay a lot longer in business with that many clients in such a short period of time. So congratulations on that success. Has your background always been in healthcare or healthcare technology of some sorts? What's your background?
Absolutely not. So my brother and I started the company together. Mm-hmm. His background is healthcare, 20-year practicing clinician, did his residency at Yale. He's the brains, I'm the muscle.
Okay.
I have a great deal of experience in regards to managing companies, technology companies, have had a lot of M&A activity, have a deep reservoir of experience when it comes to venture capital and raising capital. So Patrick is an extraordinary talent who deserves credit for many of the ideas that are ChartSpan today. My job is to implement them and execute.
I do. Okay. Angela, how about your background?
My background has always been in healthcare. I started as a nurse 15 years ago and then moved through practice administration, hospital administration, realized that wasn't where my heart was. Then I got an opportunity to go work under the ONC, the Office of National Coordinators, during the time they were writing Meaningful Use. And I realized value-based care was my passion. So I brought that to ChartSpan right at 2 years ago.
Okay. And as the role of VP of Quality, what all does that entail?
So I am in charge of all of our MIPS department and MIPS activities in the company. I do all of our MIPS analysis for our clients, as well as identifying patients who have gaps in care and preventative care, and then creating initiatives to help close those gaps in care. I also oversee the annual wellness visit product and make sure that all the patients who are eligible and need an annual wellness visit are getting those.
Okay. Well, thanks for those introductions. And again, very impressive. So we'll get into the interview now. One of the things that comes up a lot is a lot of folks are critical of the U.S. health system, right? I mean, you hear it on the campaign trails. We have a sick care. We don't have a healthcare system. We spend more than any other country and we don't have any better outcomes and whatnot. It's always baffling to me how everybody seems to recognize chronic care as a major problem as far as addressing it. It drives up costs. You find out late stage and it's more expensive to treat. What do you think the reason has been that providers in general are so slow to adopt? Is it because not treating has been so much more financially rewarding than maybe preventative medicine? Is it reimbursement? Is it the technology just didn't exist because it was so overwhelming? I mean, let's face it, doctors have very limited amount of time to deal with whatever the complaint of the day is, much less the 20 other things going on that they're not going to get paid. In your opinion, why now, and why has it been slow up to this point?
I think, to be candid, there's a hypocrisy in this premise of value-based care. The entire premise of value-based care is prevention. But how do we practice medicine today? When do you see your doctor?
Yeah, right. When you have an issue, right?
When you're sick. Yeah. When does the doctor have any time to practice preventative medicine? The entire premise of value-based care was that we will provide a platform and incent providers to practice preventative care, but that isn't happening. So it's no surprise that we're making very little gains in regards to improved outcomes and reduced costs. it's one of the reasons why we're so excited about chronic care management. It's interesting. I was at a shareholder meeting of one of our venture firms a few weeks back, about 50 former healthcare executives in the room. And I asked if anyone in the room could tell me one value-based program that has factually improved outcomes and reduced costs. And not a single person could offer a program to me. That's because we're failing and we're struggling. Now, there are two programs. They are chronic care management and annual wellness visits. But the challenge is we have to provide an incentive and the bandwidth, the time, and the resources to practice preventative care. That's one of the reasons why we are so excited about chronic care management, because that entire program says, okay, doc, at Medicare and Medicaid, we're going to put our money where our mouth is, and we're going to reimburse you if you will practice preventative care. And I love the criteria that they put in place. You are not allowed to physically see the patient in order to deliver CCM services. You must communicate with the patient on the patient's terms, and you must do it in a preventative mode. And we'll reimburse you roughly $42 if you're a traditional practice, or $67 if you're an FQHC or RHC every month per patient. That is sensible. We need more programs like chronic care management if we're really going to try to move the needle and practice preventative medicine.
Yeah, I couldn't agree more. And I think the reimbursement is also key. I do think that the reality is, and this is something that I think is just human nature, but doctors do have very limited access or availability of their time. And certainly the model up to this point has been financial incentives that have been counterproductive to wellness, because obviously if they're sick, they come in more and more frequent, and that's not always a good thing. One thing that I'm sure comes up a lot, and I know we see it on our end, and I should have mentioned this in the beginning. I usually do give a little disclaimer. Coker has historically, and probably will always maintain, an arm's length relationship with vendors. We don't have any financial affiliations, no conflicts of interest. And that's by design, because as consultants, we go in all the time and people ask us for our opinions. We recommend systems. I know you guys, for example, work with Azalea, that you have a good relationship with, a lot of good interoperability. But the question we get, or the reaction that we get a lot of times when we bring this up, especially the leadership, CMOs, CFOs, CEOs, their first reaction is going to be is, you mean to tell me we spent millions of dollars on fill in the blank system and it can't do this? And so there's this inherent belief that my system does wellness. My system has a report. My vendor told me, is to actually call any vendor. They'll say, oh yeah, we do wellness. We can do chronic care. Or maybe they have a partner. Where do you guys, how do you fight that battle? Because I know the difference. I mean, clearly you're a focus, you're going out, you're identifying patients at risk. You've actually got the stats to prove it, that you're able to show a nice return and some value. But how do you address that misconception that EHRs can do what you do?
So we have a 100,000 square foot facility an hour and a half north of here with 200 clinicians who every day are doing the hard work around chronic care management. With all due respect to my brethren at EHRs, you may have a module that empowers the practice to do it, but the practice will do the work, not you. Right. And what I often say is, I'll give you my software for free. It's worthless. Who's going to populate all those data fields? Right? It's clinicians, it's data folks, it's enrollment specialists. 80% of my costs last month on my P&L were labor. This is really hard to pull off unless you have a lot of people that cost a lot of money. That's why we love our position in this marketplace. We're strictly pay for performance. You're not going to pay me for anything until I generate new revenue for you. I'm going to do the work. I'm going to pay the costs. I'm going to take the margin squeeze if I can't execute, but I'm only going to get paid when I generate that new revenue for you. And that really separates us in this market.
Yeah, I would say significantly separation. Most vendors are built on a revenue recognition model, subscription model, licensing model, where you pay whether you get the benefits of the tool or not. So it sounds like you have some powerful technology that you're also augmenting with the labor. That's and I see that not just in this area, but you can take any software. If you don't have the resources, the people, very powerful analytics tools, very capable of measuring a lot of things, but they just don't follow through with the implementation. Maybe it's capacity, maybe it's lack of knowledge. I mean, name the reason, but that is a major problem. Is they don't always fully implement to the system's capabilities. So would you say that's one of the major distinguishing factors here, is that you actually put the people with the technology to drive it?
Absolutely. One of the challenges you have is that in the chronic care management space, and let's keep in mind, it's a space that's only 3.5 years old. Every Tom, Dick, and Harry who has a spreadsheet and a nurse thinks he can get into this business. And what's interesting is, for me, the most predictable part operationally is the clinical encounter that my clinicians engage in every month with the patients. The hardest part, and where most organizations and other vendors fail, is the data. How are you going to get the data out to maximize the cohort? And by the way, that data is messy. Just because you have a CCDA, you do not have all the information that you need. So you have to be very good at being agnostic with any EHR vendor to pull out the data and identify eligible patient panels, or you'll never achieve any real volume. Then you have to have a very good client services team, because there's education that has to happen on the street level with the providers, with the clinical staff, with the patient. Who's going to do all of that work? You have to have a really robust call center. We've raised more than $30 million, and most of it has gone into the infrastructure and the plumbing of both our enrollment and our clinical call centers. By the way, clinicians are terrible at enrolling patients in this program. I know, because I used to try in the early days. By the way, don't ask me to operate. Don't ask me to deliver, care to somebody. But you have to understand the persona and the processes by which you're going to enroll patients and hire enrollment specialists. Then you've got to have really robust technology that the patient uses, that the provider uses, that your own clinicians use, that other providers along the care continuum use. Right. You've got to be able to automate billing. There's just so many things other than the clinical encounter. And that's what we're really good at, is understanding those things in the periphery and mastering them.
And Angela, maybe you want to comment. John was talking about that you guys are obsessed with the details and the quality and whatnot. Describe maybe how you reconcile data between what's coming in from your clients' members. Obviously, I assume there's some checks and balances and a reconciliation. Is that done electronically? How do you ingest the information in your system so your team members can react to it?
Yeah, so along the same lines we were talking about EHRs, they do a decent job of giving us reports and giving us dashboards for the MIPS and quality reports and measures, but it's only as good as the report shows. Right. So what we do is we take that electronic report or the QRDA files. We'll pull those down out of the EHR, and we've written algorithms to identify the patients, of course, who are in the gaps, who need those preventative services or measures. If they are enrolled in chronic care management, then we have a special script that we talk to the patient about closing those gaps in care. So it is electronic, and that's kind of also, what sets us apart is that the EHR, sure, you have a report in your EHR. Now, what are you going to do with it? Practice managers have thousands of things on their plate, and MIPS is one of those things, but usually often is pushed to the very side, sure. And something they don't care about until the end of December, and then they kind of freak out, which everybody does. Right. So having us throughout the year to have an extra set of eyes, an extra set of hands in those reports, looking at those things that perhaps someone is missing in the practice, bringing their attention to it and fixing it early in the year rather than being reactionary and fixing it at the end of the year helps drive those scores.
I want to bridge a gap for your listeners who might say, okay, I get the chronic care management piece. Why are they also focused on quality and MIPS? First of all, a majority of our customers scored a perfect 100 quality score last year. Our aggregate score was 95.29, and every single one of our customers was in the $500 million bonus pool. Let me explain why. If you really want to get a great quality score, stand up a chronic care management program. And here's a real life workflow. Angela and her team every month are working with the quality team at our clients, and they'll look at the quality measures. And one of those measures, for instance, is what percentage of your patients over the age of 65 have or have not had a pneumococcal vaccination in the last 12 months. Well, Angela identifies the missing patients in the numerator and uses our logic to send instructions down to the clinical team. When they open that enrolled chronic care management patient's file the next month, up comes a pop-up that says, make sure we send this patient back to the practice, schedule an appointment so we can have a pneumococcal vaccination. Guess what? You're going to score a perfect 100 on that measure. And we make sure we focus on measures that we can execute and move the needle for with the chronic care management program. Right. So it's no coincidence that, I'm not sure there's any organization in the country that has the quality scores that we've delivered in the aggregate. And the truth is, the reason we're able to be so successful are the chronic care management programs we run.
Right. And it does. And again, I'll go back to, it sounds like you're augmenting the technology with the humans that are able to have a level of thinking that oftentimes computers fall short, to make judgment calls and whatnot. What's your relationship like with the payers? Do you sell to payers? Do payers oftentimes come to you and say, we have a plan that our doctors are not in compliance with, or do payers not like you very much because you are helping people score so well, and obviously that drives more incentives and whatnot. Just maybe describe your relationship with the payers.
Our relationship today is entirely with the provider. The payers love us. They love us because you just look at the claims data and you look at the cost reductions we're delivering. 4.7% reduction in hospitalizations, 6% on AWVs. So the payers really like us. Now, that's beginning to change for us because as we move into Medicaid, we're probably going to be dealing with payers directly for managed Medicaid as we go state by state. But today in Medicare, we contract directly with the provider. We deliver the service on behalf of the provider. We automate their billing, and we don't get between the provider and the payer. The provider submits that billing to the clearinghouse and gets reimbursed.
One of my questions later was what's next for ChartSpan, so I'll jump ahead a little bit. But could you ever see yourself taking this data and going back to the payers and renegotiating contracts based on the savings? I mean, especially in a shared savings plan, those plans are oftentimes predicated on how do we distribute this pot of money that has been saved as a result of our quality. That I think our hospitals and physician practices really struggle with that because they're still in a productivity-based mindset. We compensate doctors based on how many patients seen or tests ordered and whatnot. And so I think we see a lot of hospitals struggle with how do we figure out how to redistribute or reallocate the savings? How do we measure it? Who's really responsible for these outcomes? Those kind of things. So would you ever see your company getting into negotiating better contracts based on these results?
Absolutely. In fact, that's an initiative for us at the end of this year, beginning of next year, to get into capitated and at-risk models so that we can sign up for risk as well, because we know the data shows us what the clinical improvements and the cost reductions are. And we want to have a seat at that table when you start looking at those at-risk plans. We just hired a high-profile sales executive in Florida where you have a high density of capitated at-risk models, and we expect to start participating in those late this year, early next year.
And I'm sure you know this, but there's a whole market of industries that, whether it's an IPA, a PHO, an MSO, and accountable care, that's the whole model, is to bring multiple stakeholders, caregivers together to strengthen numbers, but also to drive better reimbursement through contracting. You do have to have some legal definitions that get met, such as becoming clinically integrated, single repository, sharing the data. So there are some stark antitrust laws that go into that, but there's a significant opportunity, in my opinion, in that space as well. Let's shift a little bit around what the implementation looks like, because this, let's be honest, this is a little bit overwhelming for a lot of folks. Maybe that's why you're so successful, because you come in and say, look, we'll take it off your plate and manage it for you. You just wait on the checks to roll in. Is it that turnkey? Am I oversimplifying it? I mean, how do you, if a doctor was ready to go with your services, what would that look like?
Sure. So it is critically important that we don't put one more burden on the provider. their day is full. They cannot do anything. So the truth is, yes, 99% of everything that happens is done on our side of the fence. Beyond the clinical encounter, I mentioned the data piece earlier. I mentioned the training and the onboarding. The real hard part of chronic care management is actually the enrollment of the patient, of which almost no practice or health system is skilled at doing. The truth is 72%, according to CMS, of all Medicare and Medicare Advantage patients are eligible for this program. So when we go in and we have a contract for 10,000 patients, we know 7,200 are going to be eligible once we've done the identification. Getting a measurable amount of those patients enrolled in the program when 70% have a copay is the real challenge of chronic care management. We make sure that we tell every single patient what their cost obligation is, but promote all the things that we do for them in this kind of concierge membership care coordination program. You have to define value. You have to be able to overcome objections. And our target is around 55% of that eligible patient population to get them enrolled. Of all the things that we do really well, enrollment is one of them. And it's one of the reasons why we have the largest enrolled patient population in the U.S.
So just to be clear, you're directly engaging the patient on behalf of the provider. You're answering the questions, picking up the phone, you're responding to them. You're managing that aspect of these programs.
When I call a patient, I identify myself as Jon-Michial Carter, a care coordinator for Dr. Smith. We are one and the same, and I am a member of Dr. Smith's team. And I make sure I'm following all the clinical protocols, all the disease state activities, and we create an inventory of those things. So all of our clinicians are being prompted with our technology during that call to deliver those services as defined.
You mentioned in the beginning that you guys really are not compensated until the provider's compensated. Is your model based on a revenue share or a percentage, or is it a fixed fee per patient? How do you get paid?
It is the fixed fee. We take about 65% of the total reimbursable amount. But remember, we're paying all the costs. We're doing all the work on our side. So it's about, at full copay collection, it can be as high as 35%. If you're at the national average, which is about 82% copay collection, you're going to be somewhere between 27 to 30% net margins on the total reimbursable amount.
And would you say, and I know I've looked at some of your stats in the past, but the ROI is pretty significant, I take it, right? If this is compensation that today a practice just wouldn't be participating in, basically they're just not doing it, or, I mean, they're eligible for it, the patients are eligible for it, but it's just basically money being left on the table.
That's right. That's right. You're probably hard pressed to tell me anything in healthcare that has those type of margins attached to it. So yeah, it can be. I mean, most important, let's keep perspective. The improved outcomes is why there's cost savings, right? So there's a dramatic improvement in outcomes. I like to tell everybody, we know that Medicare saves $74 per patient per month if the patient's been in the program for at least a year. That's Medicare's claims data. We know that last month there were 61 million Medicare and Medicare Advantage patients. 72% are eligible for this program. So that's 45 million patients. Take 45 million times $74 per patient per month. You want to fix healthcare? Launch a chronic care management program.
Yeah, that's, when I opened up the interview, that's always been the baffling part, because there's not a single person that doesn't disagree with the fact that that's where the bulk of our money and cost is. In fact, I've seen stats where 80% of all your healthcare spend will come in those last final years, much of which could have all been avoided had you had early intervention, had you had preventative stuff done. A lot of these illnesses that are extremely expensive to treat late stage are very inexpensive to treat early stage, but we just don't intervene, soon enough.
And that's one of the things I remind, people that are listening. This is not case management. When that patient's a high utilizer, when they've been to the hospital, we fail. That's why 3 out of 4 patients are eligible for this program. This is low-level care coordination. Our job is to prevent exacerbation, prevent you from being a high utilizer. I hope you're running a case management program, but that's not what we do. We provide care coordination.
Absolutely.
And CMS makes that distinction with transitional care management, or TCM. That's when the patient's been to the hospital. That's a different service. That's a higher paying service, because that patient now has stepped away from the preventative, and now that we're performing reactionary medicine,
right.
as well as in the distinction for chronic care management, excluding end-stage renal disease and things like that. It's beyond time, if you will, for those patients to remain well. So CMS made that distinction.
Well, this has been extremely informative, and just as mostly for the audience benefit, Coker does not offer any technology solutions, but we do a lot of services around value path, helping organizations with care transformation so they can set up and become a culture of compliance, outcomes, quality. We work a lot alongside of innovators and vendors like yourself of helping establish the program, maybe if they need an objective third party. Sometimes strong ROI claims, because every vendor's throwing out numbers and stats, it can be very beneficial to have an objective third party do some pro formas or validate that. Oftentimes people come to us to help set up their quality initiatives, whether it's forming a CIN, whether it's forming an ACO, working with their local IPAs. And, in our opinion, data has become the new currency. So we're working with innovators like yourself to help people leverage the information, specifically their outcomes. Because as you begin to shift from volume to value and we transition into a reimbursement system that's going to be predicated on outcome, I can see a scenario where we're going to have the haves and have not. If you're not already there demonstrating the quality, proving that you're able to do these things, and showing some actual results, you may really be compromised as it relates to reimbursement, assuming the trends continue the way they are, which I see no reason why the payers are really moving away from the volume-based reimbursement and shifting more to outcomes. So this is helpful. Let's end on how someone would go about getting more information about ChartSpan. I know there's a website, obviously they can go there, but do you guys have direct sales reps that come out and do demos? You do that over the web. What's the best way to get more information?
Yeah, to keep it simple, go to chartspan.com, chart as in a medical chart, span as in the horizon, chartspan.com, and just let us know online that you're interested. And then, so we have folks who are subject matter experts who are out in the field, and they'll come by and sit down and they'll try to understand, are you interested in a chronic care management program? Are you challenged with quality and your quality scores affecting your fee-for-service reimbursement? And we'll take our value-based care model and we'll tailor it and customize it based on what works for you. And again, it's a pay-for-performance model, so you've got no risk.
And I assume you, in the sales process or during the vetting, you can show some models using their data. You do some what-if scenarios. Had you been using it, this is what you can expect as a return. This is how this will work. So you have, I assume, plug and play type models where you could put their own data in there and run some scenarios for them. Is that?
Yeah, pro formas are a big part of how we sell. I hate narratives. I want to see data, right? Sure. I want to see actual numbers. And then I, as the CEO of the company, want to be held accountable for those a year, 2, 3 years into our relationship. So we make sure we forecast accurately. We use the specific data of that customer. And then we make sure every month we're monitoring outcomes and revenue performance, and we're hitting those thresholds and KPIs.
Right. Outstanding. Well, John and Angela, I cannot thank you guys enough for making the drive over to our offices. We always are very honored and appreciative anytime someone drops by. This is extremely informative. I think it's very timely. And again, if anyone needs additional information on ChartSpan, hit their website. And of course, you're always welcome to contact us here at the Coker Group. And again, thank you everyone for listening, and thank you guys for coming.
Delighted. Thanks for having us.
Thanks for having us.